Pedro, thank you so much. So I've looked at this case many times. I'm not sure what I would have done different. And that's why I thought maybe I'll show it to the experts here, or somebody in the audience would like to comment. But one of the, as Dr. Moreno mentioned, this is all I do. It's been 26 years of doing it. And one of the big lessons I can tell you for all of you involved with STEMI is that even in the best of programs, our communications are really, they need to improve, particularly with the ER physicians, and I'll show you glaring issues here. So this is at 10:30 in the morning. How hard could STEMI be at 10:30 in the morning? And I'm in the cath lab, and I got a frantic call from the ER physician that we have this relatively young patient, and they are doing CPR in the EMS, and that's all the history got, and there's no history of any PCI. So young patient, no previous history of PCI, and they are doing CPR in the ambulance. So let's try to see if something could be done, but here we go. So I come down, the hospital doesn't have one of these automated Lucas kind of automatic chest compressor. So two of the technicians are there, I'm there, and we're looking down the road looking for the ambulance. And here is the first mistake. We're looking the wrong way. So the patient is actually had a cardiac arrest on one of the cruise ships off Miami. A massive acute anterior wall MI, and it really is a tribute to how good the paramedics are that in this mode of delivery, transporting the patient. They've been doing constant CPR in the helicopter, and the patient is not young, it's 72, and has a massive acute anterior wall MI, and I'm not sure where exactly was this EKG performed, and there is another strip which shows a complete heart block. So we get the patient ongoing CPR. One of the nurses quickly jumped onto the stretcher and continued to do, and quickly took a picture. I don't know why I chose the left groin. I normally use the right. And quickly put in a pacemaker, and placing the guiding catheter. Already this is happening with the CPR, and tried different guiding catheters. I think this is finally an EBU which will go there, and you realize, okay, so this is again going back to we can talk about the technical parts if something could have been done different, but just look at the history. No history of PCI. I mean, this lady has got something like 8 to 10 stents or something, and of course, the culprit here is the left main ostium LAD, and all of it is thrombotically occluded. And again, what is more challenging is the continuing CPR. Just about every guide wire which we had in the cath lab, we kept opening. I traditionally start with the hydrophilic wire. We used a choice PT, extra support, whisper wire, and then whatever else was there, going on to more and more stiffer wires. And I mean, just about every challenge you can, there's clearly a dense thrombotically occluded, previously placed numerous stents, I think at least 3 or 4 overlapping, and the wire, of course, would not go through the occluded segment, and I think I proceeded. This may have been the 4th or the 5th or the 6th wire. The exercise will continue. I use a support catheter, tried wiring even the left circumflex to give a little support to see if something could be taken antegrade. And again, I think another view demonstrated that the only way the wire would exit through the struts. And just about every wire, every support, and here it's very deceptive. The wire is through the struts. And even tried to make a little loop on one of the wires and try to kind of daughter it through, but here, thought that maybe, let's see where maybe we can dilate with the balloon at the site before it exits, but again, nothing, no antegrade flow forward. Once again, trying to support the left circumflex. I think at this moment, I thought maybe quickly stenting the ostium of the left circumflex maybe would give some antegrade flow, and did that quickly. And of course, not only did that not improve things, but even the stent is down, the circ is down. Even tried something further, low inflation, I think 2.5 or 3.0 balloon, which I had, I inflated it in the very proximal and just tried to daughter it without any wire as a last frustrating attempt, but nothing, got a little more flow there, but the patient never stopped resting, and this is almost back to where we were, and this is 45 minutes into the case we pronounced. We'll be happy to take any recommendations from
Very
people
difficult
in
case,
the audience.
tremendous difficult case. Let's look at the non-selective picture you had at the beginning of the case. Before you selectively engage the left main. Here, yeah. So it's terrible, yeah, the whole thing. Okay.
Dr. Mehta, do you ever think about, do you put an impella in first before?
Look, if we had a,
or a balloon
would have
pump,
been
or,
one of the considerations, did think about it, but in this case, would that have made any difference, antegrade? Maybe, look, I did think about it later, possible.
I mean, I think that somebody like this, even if the blood pressure was so-so at this point, you've had multiple arrests, so the LV ischemia is really building up, and you really need to start with an impella first before you do anything else. The LED's gone, you got a stent thrombosis, and things just got deteriorated from there. It's impossible to get flow down a vessel, even if you open up and remove the obstruction, if you don't have any central aortic pressure, or very little.
Absolutely. John?
Yeah, I think that's the key. I think what happens is they've gotten so good at getting patients like this to us. And this is a person who would die in the field. And it's great that you bring it up because we're going to have to try now to save everybody. And you did, and thank God it was you, and we gave it the best shot. But if we're helicoptering people in, there's a goal, there's a standard here that, is pretty high to meet.
Nathan?
Yeah, I agree. It's an out-of-hospital arrest. I imagine a long CPR time never achieved ROSC. So, even things like ECMO, which you would or should be thinking. Obviously, I think we all understand that early on, then it becomes an LV problem, and that has to be managed first, but clearly not eligible. I'd be curious, obviously, usually we're used to doing a lot of STEMIs. These are not hard to cross lesions. They're sick patients, but usually the technical aspects are not especially hard. But, this is a post-stented patient, unclear history. The fact that it was so hard, I was curious if I don't know if there was an RCA shot done. If we went straight with the guide, which you might have done. If we saw complete filling of the LED, that might have kind of changed a little bit of how it was approached. But I think it's clearly an LED infarct, but it might have been that it was a critical ISR that got the thrombosed.
Samin, would you have done anything different here? Well, let's
only
at
thing
least...
is LV support immediately, ECMO.
Yeah, clearly. No ECMO at this institution. Look, one of the issues which is happening is some of the institutions where you're doing it don't even have a surgical standby. So this is, of course, both Impella and ECMO were in the considerations, may have made a difference. Really, I've, as I mentioned, I have questioned myself what could have been different. But clearly, things which can be done different if you do a lot of STEMI is to continue improving the communications with the ER. Thank you so much.